coverage just when that critical care is most necessary. About a year ago, earlier this year actually, in March, the Centers for Medicaid and Medicare Services released an interim final rule which gave authority to insurers offering plans on the exchanges to deny nonprofit charities from helping with this premium assistance. So since patients with rare diseases and catastrophic illnesses disproportionately use those kinds of programs, this rule has had the effect of pushing individuals with these pre-existing conditions off the health plans they had purchased in an exchange. And that means fewer insured Americans, more patients with complex conditions in the federal safety net. And under the ACA, the law provides federal subsidies for health insurance. Why then did the Obama administration offer a ruling that prevents Americans from doing the same out of charity when they see a need? Well, since the release of this interim final rule back in March, plans in actually more than 35 states, and this number of states keep climbing, have announced a prohibition, which indicates more than ever the need for the approval and passage of this bill to address this critical issue. The Access to Marketplace Insurance Act, H.R. 3742, would remove the handcuffs from private charities, would allow them to help insured patients who need help by helping to pay their premiums. Now, the CMS mandates that third-party payments must be accepted only from certain entities. And nonprofit organizations, churches, those are excluded at this point. But those entities include federal programs, Indian tribal entities, and the Ryan White HIV/AIDS program. And the CMS takes a position that insurance carriers can take third-party payments from nonprofits if such payments meet certain criteria, and they should cover the patient for the entire planned policy year, and they should not consider health status in deciding whether to provide assistance. Now, we do have, Congressman Kramer has been able to generate some co-sponsors on this bill, and we have many more we're expecting to sign on, but at this point right now, we have co-sponsors on the bill, including Representative Sheila Jackson-Lee, a Democrat from Texas, Representative Alan Grayson, a Democrat from Florida, Representative Griffith Morgan, a Republican from Virginia, and Representative Gerald Connolly, a Democrat from Virginia. So you can see it has bipartisan support, and we have a lot of interest in this bill, and it's growing. So we urge you to push for this bill, contact your congressional office, advocate for it, and that's why we're on the phone in the webinar with you today. And Kelly, I'll ask you, what can these groups be doing to help push and advocate for H.R. 3742 from your perspective?
Thank you. Thank you also to the event today for having us on. Again, there's so many patients that are being impacted by this across the country, so we really appreciate the time to bring this to people's attention, and also Congressman Kramer and his staff for all of their wonderful support. What you can be doing right now is reaching out to PSI, to the American Kidney Fund, to let us know that you might be interested in supporting. We'll be putting together a lot of materials moving forward with organizations who are supporting. We already have quite a few, but if you're interested in adding your logo to those materials, please let us know. And I'll give you my contact information in just a second. Also coming up next year, if you're having an advocacy day, if you're bringing patients to the Hill, or if it's something that you might want to use for those types of events, we would love that type of support. Also, if there's any patients that you know from your organizations that might be affected, patient stories are so impactful and they really hit home, as you all know. So we're trying to gather those stories, again, to really show this impact for people. This new access has been wonderful, but for patients with these types of conditions, if they can't access these new policies, again, the cost is going to be shifted back where we don't want it to go. We want them to have the best lives possible available and the most access to these new policies. So again, let us know if you would like to support. My name again is Kelly Fitzgerald. My email is kfitzgerald@uneedpsi.org. I'm also happy to send that out at the end, or you can contact Congressman Kramer's office as well. Thank you so much.
Very good, Kelly. And I will give you the number for Congressman Kramer's office. And just ask for me, and I'll be glad to visit with you as well. Area code is 202, and then it's 225-2611. And my email address, if you would like to contact me, is Rick, R-I-C-K .Collins, C-O-L-L-I-N. No S on that last name. I fight that all the time. So it's rick.collins, and then at mail, M-A-I-L, .house.gov, G-O-V. So be glad to hear from you if you have any questions, or if there's anything that I can be doing to help advocate for you with this bill. We sure welcome your support and interest on this, because it's a vital piece of legislation that needs to address a real problem that's going on right now with health insurance coverage.
Yeah. And our briefing tomorrow actually starts at 10 a.m. It's 2203 Rayburn. We'll have a couple patients speaking as well as PSI and the American Kidney Fund, so we hope you'll join us.
Great. Thank you all for that great information on this legislation. I want to put it out to the advocates on the line and anybody else listening in. If you have any questions about the legislation whatsoever, please feel free to message me using the Q&A function or chat. Again, the phone lines are open, so if you want to ask a question directly, you can. Right now I have a question on the line. And the question about the legislation is, what was the rationale for the original prohibition of non-federal or state subsidies? Again, Rick, this question goes to you.
Okay. Well, Kelly, I'm going to defer to you if you would like to take that one on.
Yeah. Again, the question was, what was the rationale for the original prohibition of non-federal or state subsidies?
So I want to make sure I understand the question. I know we're using the chat function, so I hope you'll give us a second. The rationale, do you mean originally when the other three entities were also barred from assistance? The three that are being accepted now?
Yeah, I believe that is the question.
Okay. Again, I think that the original rationale that we've been given by CMS, again, is that essentially some flexibility was wanted to be given to the plans in these types of instances. I think that it is also, though, difficult for me to give a good answer as far as rationale, because some of the things that we've been told don't necessarily make a lot of sense when you have policies that are meant for people who had pre-existing conditions before, who in many cases couldn't find any type of insurance. They now have these, but then you're going to give power to an insurer to essentially reject an opportunity for them to access that policy. So that's some of the rationale that we've been given. But again, we don't believe that that answers the question or is sufficient for these patients. So that's why we're moving ahead. I hope that answers your question a bit.
Yeah. And Kelly, I just wanted to get more clarification too on your email. I know you've asked the community that if anybody is participating in advocacy days, they should coordinate with you, and also you're looking to collect patient stories applicable to the legislation. So if you could spell out your email for me one time, I think that would be helpful.
Sure. Sorry, I know the end is confusing. That's K Fitzgerald, Fitzgerald, at U like umbrella, N as in Nancy, EED, P as in Paul, S as in Sally, I as in igloo.org.
.org. Thank you so much.
Yeah.
I know a lot of our advocates participate in advocacy days on Capitol Hill fairly regularly throughout the year. So if there is anybody on the line that is participating in an advocacy day and would like to connect their group to this legislation, please contact Kelly. And they are also looking to collect patient stories applicable to the legislation. Well, right now I just want to thank Kelly and Rick for coming on to the call today. Again, if you have any questions whatsoever, you can email them, and I'll post their emails on rareadvocates.org. Thank you so much for your guys' time today. We really appreciate it.
Thank you, Andy, very much, and thank you, Kelly.
Thanks, everyone.
All right. With us next is talking about the Re-Authorizing the Priority Review Voucher Program. Nancy Goodman is on the line. Nancy, are you there?
Yes, I am. Thank you so much for giving me this opportunity. And hello, everybody. So what I would like to talk about today is the reauthorization of the Creating Hope Act, which created pediatric priority review vouchers. For those of you who are not familiar with the Priority Review Voucher Program, it's a program to incentivize drug development for pediatric rare diseases. The way it works is if a company or academic creates a drug and receives FDA approval for it, and this drug is for a pediatric rare disease, the drug receives a voucher. And the voucher is fully tradable. The voucher holder may receive a faster FDA review on any other drug, not necessarily a pediatric rare disease drug, but perhaps, for example, a blockbuster heart disease drug. So the vouchers have been trading. One traded this past summer for $350 million. This program works. It's very exciting. It was passed as a pilot program, and now our goal is to get it permanently reauthorized so that it can be an incentive which businesses incorporate into their business development plans as they elect to undertake more pediatric rare disease drug development than they have in the past. So where are we? This past Congress, we were thrilled that the Advancing Hope Act, to reauthorize the Creating Hope Act, was introduced in both the House and Senate as H.R. 1537 and S. 1878. The House bill was incorporated into 21st Century Cures, which is terrific, and we are very optimistic that the Senate version will be reincorporated as well. So what now is our cause for concern? Our cause for concern is that 21st Century Cures isn't moving fast enough for us. The Creating Hope Act will expire on St. Patrick's Day, March 14th, 2016, and we are concerned that cures will not be passed by then. Chairman Upton assures us that it will. We're pretty nervous, and of course we are huge supporters of 21st Century Cures, but we do want to ensure that this is passed. The Creating Hope Act is not an exclusively pediatric cancer bill. We also have a legislative provision that we've been working on, the Kids Innovative Drug Initiative, which would reform the Pediatric Research Equity Act so that it applied to pediatric cancer. At this time, it applies to disease, what the Pediatric Research Equity Act, or PREA, does is it requires companies developing drugs for adults to also develop those drugs for kids when kids have the same indication as the adults. So cancer is a specific case insofar as drugs aren't developed for prostate cancer or breast cancer anymore. They're developed by molecular target. And kids' cancers, which are different, do share those targets. So we are working with both the House and Senate to find ways to introduce language and get this rolling, if not in 21st Century Cures, although we're still aiming for 21st Century Cures, then also PDUFA. We think is a lot of support from many lead stakeholders, including hospitals, the U.S. government, we believe, hundreds of pediatric cancer organizations, and So that's where we are. We're working to reauthorize the Creating Hope Act and introduce the KIDS Initiative.
Thank you, Nancy. That was such a very clear and thorough report on the reauthorizing the Priority Review Voucher Program. Does anybody on the line have any questions for Nancy about, next steps or things we hope to see? Okay, well, thank you very much, Nancy, again for that report. If you have any questions whatsoever for Nancy, you can reach her with the Kids v. Cancer organization. All right, well, thank you so much, Nancy.
Thank you.
Okay, next on the line we have Tara Burke, a policy analyst for the Association for Molecular Pathology. She will be talking about a proposal for modernization of Clia regulations. Tara, are you on the line?
I am. Thank you, Andy. Hello, everyone. I just want to thank Andy and the rest of RDLA for letting AMP kind of explain our proposal today. We kind of get narrowed in on the details of laboratory developed procedures, so I'm going to try to keep it pretty general, but please feel free to reach out to me afterwards or ask questions at any time, and I'm happy to stop and back up if you guys are confused. Just a general overview about AMP is that we are a medical and professional association. We represent over 2,300 physicians, doctoral scientists, and medical technologists who are involved with laboratory testing related to molecular biology, genetics, and genomics. Our members are from the government, academic medicine, clinical testing laboratories, and the in-vitro diagnostics industry. AMP this year worked really hard to develop a proposal to modernize the current Clia regulations that currently regulate laboratory-developed testing procedures. The Clia regulations are currently housed under CMS, and our proposal updates those regulations to accommodate recent advances in science and technology, laboratory science and technology, to account for those changes and to address any stakeholder concerns. So AMP worked really hard within the organization and with other stakeholders, including other professional organizations, to create this proposal. We feel that this proposal presents a path forward for these testing procedures used in many contexts, including public health emergencies, determining risk associated with inherited diseases, risk associated with developing a disease or condition, as well as for patients, informing patients for treatments, including those with rare diseases. The desired outcomes of our proposal were that patients receive the most appropriate test for their condition. Listed here, I may not go through all of these depending on time, but that laboratory-developed testing procedures, or LDPs, as I will most likely refer to them here on out, are accurate, precise, clinically relevant, and monitored for continued quality performance. We have advocated for a long time, and our proposal addresses this, is that healthcare professionals are able to provide professional services to their patients without undue restrictions. And our proposal preserves the ability of the laboratory community to provide surge capacity in public health emergencies, allows patients a variety of testing options, and a key pillar was that the regulatory oversight doesn't slow innovation or constrain flexibility and adaptability or limit a test sustainability. So our proposal is built on 3 pillars, which are shown here, and which are enhancing transparency, ensuring quality, and preserving innovation. So, and this slide just kind of backs up a little bit, and I just want to reiterate there are two types of tests. So there are two fundamental differences between laboratory-developed testing procedures and in vitro diagnostic kits. And so on the left, there are some qualities that explain LDPs, which are developed by a healthcare professional, often at the request of your treating physician. They're conducted within a lab that designed and validated that LDP. Those LDPs are evaluated by third-party experts and continuously monitored, and the ability to modify as needed in response to a new technology or understanding. In vitro diagnostic kits are different. They're developed by a manufacturer. They're box and ship tests. And those tests are evaluated by the FDA. The LDPs are evaluated under CMS. The information for these kits are not always accessible, which prevents third parties from being able to continuously monitor. And manufacturers must, again, complete FDA review system if they want to modify the test at all. So next slide, please. Thanks. Regardless, we feel that the information a patient receives should be verified, accurate, and clinically relevant. And we believe that there are ways to augment the current regulatory process to ensure all LDPs meet these criteria without dramatically reducing patient access. So why should we modernize the Clia regulations? So as I mentioned earlier, CMS has a long history of holding laboratory practices to certain regulatory standards. This process can and should be improved regardless of any other activity on the issue. These regulations were developed in the 1980s and do not address recent advances in medicine. As a result of modernizing the Clia regulations, the proposal offers a streamlined, cost-effective approach to addressing clinical validity, transparency, and other issues. So the next slide just shows kind of a schematic overview of what tests we're specifically dealing with in the proposal. So if you have all tests here at the top, you have a series of high-complexity tests, and then you have under high-complexity laboratory developed testing procedures, or LDPs. Those are, in our proposal, divided into high risk, moderate, and risk and low risk. And this, our proposal would elevate the regulations that apply to all LDPs, so high, moderate, and low. The next slide lists our key features, the proposal's key features. Our proposal is tiered and it's risk-based, meaning that the way that a procedure is regulated is based on the risk of the test: high, medium, moderate, or low. Our proposal assures both analytical and clinical validity without jeopardizing innovation. And if any of you aren't familiar with analytical and clinical validity, analytical validity means that a test is accurate and precise, measuring for what it's supposed to measure, a certain analyte or biomarker. And clinical validity means the association of a certain biomarker with the presence, absence, predisposition to, or risk of a specific clinical condition. So the proposal will ensure both of those. It provides for rapid response during public health emergencies, provides transparency so physicians and patients have essential information. It levels the playing field by applying the same regulatory principles to anyone who develops an LDP. Provides for pre-introduction review of high and moderate risk LDPs. Specific consideration or special considerations for LDPs for rare diseases and compassionate use. Provides for enhanced standards, requires proficiency testing, alternative assessment for all LDPs, and avoids any duplication of activities within and between federal agencies. The next slide just gives an overview of our risk classification. And I'm not going to read each definition for you, but I highlighted, I think, what's most applicable to rare diseases is that in the low category, LDPs used for rare diseases for public health emergencies and for infectious agents that are not serious threats to public health are classified as low risk. We feel that most of the tests that aren't those in bold there would fall under the moderate risk category, and then we have a high category that that basically just deals with specific tests that cannot be independently verified, that have proprietary algorithms used in the test method. And then I just wanted to go over kind of the whole life of the LDP as it goes through this proposed regulatory scheme. You can see that first the LDP is developed, that a lab classifies the LDP based on risk. The lab submits that LDP, if it's high or moderate, to a reviewer before offering the service to the public. CMS or a third-party reviewer reviews the LDP to ensure that it's accurate and reliable. The timing of this review is based on risk classification, and CMS is allowed to reclassify the risk, and the lab may appeal that decision. CMS creates a publicly accessible entry for LDPs. The review decision is issued, and the lab, of course, may appeal. The lab participates in proficiency testing and is inspected. LDPs that pose immediate jeopardy to laboratory patients must be reported directly to CMS. And lab is allowed to continuously improve the LDP over time. And you can see that low-risk tests do not have a pre-introduction review, but they are monitored over time. And then one thing I specifically wanted to point out related to rare diseases and that we have in our proposal is a compassionate use provision. And this is where patients with a suspected or established life-threatening conditions may be offered a certain LDP that may not have been approved yet, as long as the ordering physician has been notified that the LDP has not been approved and that the physician allows that order to proceed. There are many instances where a provision of this kind would be useful, particularly in situations where it's unclear what the underlying reasons for a set of symptoms are. In a specific situation, it may be impossible to document that the LDP is being used for a rare disease or condition until after the fact. In order to allow molecular professionals to design specific procedures, the treating physician would be able to create a compassionate use order under this provision. As a result, the patient would be able to receive the testing procedure as soon as possible. So that was a very, very brief overview. And I don't know if I mentioned at the beginning, but I'm happy to take any questions. And please feel free to reach out to me at any time for any questions. And this proposal, you know, we've taken it to the Hill, and we're working with Senate and House staff on this. It is a work in progress, even though it may say final. So if you have any concerns, especially related to rare diseases, we are more than happy to talk to you about that.
Great. Thank you so much, Tara. Tara, could you tell us your email address in case any of the advocates or anybody else on the line has any questions? Sure.
It is tburke, burke@amp.org.
Thank you so much. Now, does anybody on the line have any questions for Tara? Okay. Well, Tara, again, I want to thank you for bringing this issue to our attention, and I appreciate the fact that you're open to take questions from everybody in the community. So thank you so much, Tara, for being on the line today.
Thank you.
Okay. All right. Next on the line is my colleague Max Bronstein. He is our Senior Director of Advocacy and Science Policy for the Every Life Foundation for Rare Disease, and he is here to give us some Capitol Hill updates.
Thank you, Andy. So a lot has actually happened in the past month. So yeah, I'm kind of excited to give this update. I want to talk a bit about 21st Century Cures. I know Nancy mentioned this earlier, but I wanted to add on a little bit more information here. I hope you are all familiar with this piece of legislation, but if you're not already, this is something that actually got started over a year ago, and it was led by Chairman Upton and Congresswoman DeGette, and they sort of took on the really big task of trying to change the entire biomedical ecosystem in the U.S. So they spent a long time listening to a lot of stakeholders, patients, doctors, agency heads, and they put out 4 draft bills, which I think individually were around 300 to 400 pages, so really substantial legislative effort here. And I think there was vision that rare disease advocates were asking for, evidence ultimately in the bill passed the House, by in a very wide partisan way of 344 to 77 in the House. So that's a really significant vote count, because that doesn't happen every day in the House. The big step forward here is to get this bill through the Senate. We have a variety of challenges on the Senate side, however. So what we've seen them do so far, this was all the way back in January, so almost a year ago now, but Senators Alexander and Burke released a white paper which highlighted some of the issues that they would like to see in their own version of this legislation. But that's actually the last thing that we've seen the committee release. So what we've been doing at the foundation, about 3 months ago, we ran a national action alert to ask the Senate to make innovation for healthier Americans a higher priority. So we had a national call-in day, and we have done Hill meetings on the Senate, and we are hopeful that we will see some kind of bill before the end of the year. In terms of the challenges with the bill, we've heard a lot about problems of how they intend to pay for certain items in the bill. So there was funding in there and FDA funding, and it's still unclear how those could be paid for. There was a budget deal that was made not too long ago between the President and Congress, and I'll get into more detail about that, but that could actually affect the negotiations here. And what we're hearing is that, theoretically any day now the Health Committee could release a draft. What's sort of frustrating about this is the committee has been saying that in 2 weeks they plan to release a draft, but they started saying that months ago. So, it's really hard to predict if and when something will come out. There's been a lot of sort of discussion and debate and rhetoric, largely driven by the presidential campaign about the cost of drugs and the price of drugs, which, of course, is a very important issue, but it actually slow down some of the work around this because it's creating controversy, and controversy is ultimately what could end up slowing down the bill even further. So I think I mentioned that, we're not likely to actually see a floor vote until sometime next year, and then path forward would be to conference the bill that the House passed with and adopt the President for his signature. So what I think you should all stay tuned for, and the way you can do this is actually by following us on social media or following us via email, action alerts, because if and when a draft comes out, and if it doesn't include provisions that the rare community fought for outside, then you can bet we're going to be reaching out to everyone and asking them to contact their senators to make sure that our voice is included. I want to talk a bit about the recent deal that was passed. So this was a deal that was negotiated largely by the President and passed by Congress. The reason why this sort of came up, the background here, was that back in 2011 there was a law passed called the Budget Control Act, which put a variety of fairly arbitrary spending caps on federal spending, and the idea behind that was to try to limit the federal deficit. But it's really problematic if you have a goal to increase funding for medical research or increase funding for FDA, because you can't do that under these caps. So there was a budget deal that was made that would actually increase the debt limit for 2 years, so it would move us away from that sort of brinksmanship approach that had been taken around this issue. And there's money that will be in there to alleviate some of the funds that were way under sequestration and were taken away under the budget cap. So it's a significant amount of money, but I wouldn't call it a windfall, and it still remains to be seen how this new funding will be spread out among the different committees that determine funding for that we've been working on for basically since the foundation started, trying to ensure that funding for NIH and FDA are the highest possible levels, and we work closely with other partners in the community, including the Coalition for Health Funding, to make sure that health programs are possible. So that's a little bit about where we stand on the budget side of things. I don't know if you guys saw, but yesterday was the hearing for the new potential new commissioner of the FDA. So he was nominated by the President, and I actually thought the hearing and the questions went rather smoothly. There was some controversy and discussion about the price of drugs, which we all anticipated, so there was no real surprises there, but most of the senators indicated their support for Dr. Califf, and that they were very excited to work with him and continuing to work on how to kind of modernize the FDA and really make sure that it's a 21st century regulatory agency. So, there were some questions about this, and our hope was that now that this nomination hearing was out of the way, we might see more movement on innovation for healthier Americans / 21st century cures. And what we heard was that the committee wanted to get this sort of hearing done so that they didn't want the hearing to be about innovation for healthier Americans. They wanted it to be about the nominees. So hopefully that means that we'll see more progress on the Senate side. So that's a few updates about where things stand on Capitol Hill. I should offer, and I'm sure many of you already know this, but if you want to see the Senate move on innovation for healthier Americans, then I definitely recommend jumping on our website, rareadvocates.org, and completing an action alert. It takes about 2 minutes to do, so it's well worth your time. Does anyone have any questions? Feel free to send them in using the chat feature, and I believe the lines are open too if someone wants to ask that way. All right, no questions. Hearing none, I'll turn it back over to Andy.
Thank you, Max. All right, for those great Capitol Hill updates. As you can see, a lot's going on, so make sure to stay tuned with RDLA and stay clued in, as we will do our best to update you on what's happening on Capitol Hill. Just this past couple weeks, RDLA has been very active, and we held our 4th annual Rare Voice Awards Gala, where we saw over 300 patient advocates, industry leaders, staff from Capitol Hill, and federal agencies. They all joined us to celebrate advocates who have given rare disease patients a voice. So we want to thank everybody for coming and thank everybody for making it just such a special night. And we look forward very much to next year's Rare Voice Awards, which we will hopefully be celebrating the passage of Innovation for Healthier Americans legislation. It'll be held November 16th, 2016 at Arena Stage, the same venue where we had it this year. If you want to see photos of the event, you can go to RDLA's Facebook page or rarevoiceawards.org. All right. So right now I'm going to talk a little bit about Rare Disease Week on Capitol Hill. It's going to be February 29th to March 3rd, 2016. Right now I want to go over some important dates to remember about Rare Disease Week on Capitol Hill. We have travel scholarships that you can apply for now at raregiving.org, and you can apply up until December 31st, 2015. So make sure if you want to apply for a travel scholarship to Rare Disease Week on Capitol Hill, make sure to get it in by the end of the year. Registration will open next year on January 4th and will close February 15th. So we give that, about a month to register for Rare Disease Week on Capitol Hill. And we'll be having 2 informational webinars, the first one being January 20th. It gives a pretty conclusive overview of Rare Disease Week. And February 23rd, we'll have our second webinar, which is to help advocates prep for their big week on Capitol Hill. And again, that's February 23rd. So just keep these dates in mind, and we'll be sure to send out reminders via email and on social media. So these are the actual dates of what's going on during Rare Disease Week on Capitol Hill. The first is Rare Disease. We'll start it with Rare Disease Day at the NIH, and then move to the Rare Disease Documentary Screening and Cocktail Reception. That's all taking place on Monday, February 29th. The next day, Tuesday, March 1st, we'll have our legislative conference at FHI 360 in Washington, D.C. That's near DuPont Circle. The following day on Wednesday, we'll have our Lobby Day, one of my favorite days of the year, where advocates go around to congressional offices trying to get their members to support pieces of rare disease legislation. The following day, Thursday, March 3rd, we'll have our Congressional Caucus. The Rare Disease Congressional Caucus will convene for a briefing, so be sure to attend that. Following that, on Thursday, we'll have our Rare Artist Reception, where we'll have our winners of the Rare Artist Contest showing off their work. So again, it's free to attend for patient advocates, and travel scholarships are available. To see event pictures from the previous years, you can go to rareadvocates.org/RDW. That stands for Rare Disease Week. So right now I'm going to talk a little bit more about the travel stipends. You can find these on raregiving.org, or you can go directly to the link at everylifefoundation.org/travel-scholarship-application. These travel scholarships are provided through the Rare Giving program, which ensure that Congress and the FDA and other government agencies have the opportunity to hear directly from the patients. In order to receive a travel stipend, advocates must attend a legislative conference on Tuesday, March 1st, and that's where the travel stipends will be given out. Advocates must provide a photo ID and a social security number, and you can use the stipends to pay for any of the travel expenses you incur, such as hotel, food, airfare, gas, and parking. The stipends will range from $300 to the $1,000 maximum, depending upon the distance the advocate has to travel. Again, you can apply online through December 31st, and we will grant as many travel stipends as possible and notify winners on January 4th. Again, there's one travel stipend per family, and we encourage all advocates to apply, but especially from those states which are of low population or from states where we haven't brought advocates to Capitol Hill. Such as Hawaii, Alaska, and some of the Midwestern states and states in the South. Again, if you know a rare disease patient from one of those states that would like to be involved in Rare Disease Week, please let them know that they can apply for a travel stipend. Okay, we also want rare disease patients to share their stories. And not only do all the advocates during Rare Disease Week get a chance to tell their story to their legislators, but they also get a chance to drop off and maybe tell the legislators some stories of patients in their districts that could not attend Capitol Hill, or Rare Disease Week on Capitol Hill. So RDLA still wants your voice to be heard if you cannot make it to DC. So make sure you share your story with the foundation, and we'll make sure that it is hand-delivered to your DC representative. Again, you can submit your RARE story at rareadvocates.org/RDW/patient stories. And you can email me for more information. Again, okay. Well, I want to thank everybody for being on the line today and for joining us for our November legislative meeting. Again, this meeting will be recorded and posted on rareadvocates.org. If you have any questions about any of the presentations on the call today, you can email me at arussell@everylifefoundation.org. And right now, I just want to put it out to all the advocates online. If you have any questions or have any issues that you would like to bring up, please feel free to use the line now and ask those questions. I guess you all are emailing me your questions right now. So I just want to thank everybody again for being on the line today and joining us. Our next RDLA meeting will be on December 16th at 2 p.m. Eastern. This will be a webinar and conference call, not an in-person meeting, just like today. And if you would like to see an agenda item on the next meeting, you can send it to me at arussell@everylifefoundation.org. Again, if you'd like to see anything on the agenda for the next meeting, please contact me. Okay. Okay, we have one question on the line from an advocate that this will be her first time coming to DC for Rare Disease Week. She's wondering what airport to fly into. Again, these questions, you can send me these questions at any point, but Della, probably the best airport to fly into is DCA or Reagan if possible. Hope that answered your question.
So there are actually two other airports in the area, so obviously, you know, there's going to be some financial decisions that have to be made, so if you can get a cheap flight into Dulles or BWI, those are possible. Just for flying into BWI could take up to an hour or more to actually get to DC, depending on where you're staying, so be aware of that. And if you fly into Dulles, which is the international airport, it can take about 30 to 60 minutes or more if there's traffic. So definitely your best option is flying into DCA, but there are alternatives out there if you can't get a good flight.
Great. Thank you, Max. All right, are there any other questions out there on the line today? All right, seeing that there's none, again, I want to thank everybody for joining us today, and I wish you guys a very, very happy Wednesday. So thank you so much, and I will speak to you soon.